Hi everyone, welcome to the session. I was just sharing just a small video. Sorry, I didn't see that you are 2 minutes past time. So it's a great pleasure meeting today once again. And because of time, I think we just start off, and the rest can then join us as we continue. And I would love to welcome. I can see our guest speaker today is in the house, Dr. Collins Jaguga. So very much welcome, Dr. Jaguga. We are really pleased to have you today. So I've made you co-host, Dr. Jaguga, so maybe you can try sharing your screen as we start.
Hi, Daniel and fellow colleagues. Just to check that you can hear me.
Yes, we can hear you, Dr. Jaguga.
Okay, great. What I'll do, I can just share my camera briefly so that you see me, and then I'll switch off. So greetings again. My name is Collins Jaguga, like Daniel has said. I'm a pharmacist by profession. I started by working in the hospital pharmacy space. I did that for 13 years and then now moved to the health system strengthening space, having worked with a few NGOs. And that's what I'm currently doing. So it's really a pleasure and an honor to talk to all of you this evening. And just a quick check again, Daniel. So the students, the participants are from which courses generally and which countries? Because I think I've seen somebody from Tanzania. So just a quick overview so that I can know the audience. Thanks.
Okay, thank you. Thank you so much, Dr. Jaguga. Yeah, I'll just do a brief introduction as we start. So we have students from different health backgrounds, not just the healthcare. We have also students from engineering, from arts. For the countries, we have 12 countries around. We have Tanzania, Kenya, Uganda, Zambia, Zimbabwe, Nigeria, Ghana, Burkina Faso, Namibia, Rwanda, and I think I haven't left any. Yeah, so and yeah, I think those ones maybe, and Cameroon, sorry. Yeah, and I believe most of the countries, luckily, I believe that you have visited them and you have worked there before. Yeah. So maybe so thank you everyone who has joined. I'll just do a brief introduction of Dr. Jaguga, then we can start off. And I really appreciate that you've been able to join today. And I really also thank Dr. Jaguga for this session. I'll be moderating this session with my co-coordinator for the program, that is Anastasia. So as we go on, in case you have any question as we go through the presentation, please feel free to share in the chat box, or once we finish, you can just raise your hand and then we'll select, then you can unmute and then ask your question. Thanks so much. So a brief introduction to our guest speaker today, Dr. Collins Jaguga. So I've had the session to attend some of the sessions that he has also given some webinars before. And Dr. Jaguga, one thing that I came to learn is a very reachable person. He always sacrifices time, and he's really willing to, engage the young people, and I really appreciate that. As Dr. Jaguga said, so he's a pharmaceutical management specialist with 20 years experience in strategic management and technical leadership of pharmaceutical services and systems in sub-Saharan Africa. He has extensive experience in developing technical strategies, implementing and managing health programs, and this is in 16 countries in Africa. Some of the countries that some of us come from, these include Chad, DRC, Ethiopia, Kenya, Lesotho, Liberia, Madagascar, Malawi, Mozambique, Rwanda, Sierra Leone, Somalia, Tanzania, Uganda, Zambia, and Zimbabwe. And his professional skills include implementation of national action plans on antimicrobial resistance, especially antimicrobial stewardship, infection prevention and control programs, categorization of antimicrobials in WHO, access, watch, and reserve, that is the AWARE classification, regulatory health system strengthening, quality assurance of healthcare products and technologies, pharmacovigilance, post-marketing surveillance, national scheduling of medicines, regional multi-country pool procurement mechanisms, country assessment of public health supply systems, development of national medicine formularies and essential medicine lists. And also others include procurement and supply chain management of healthcare products, medicines, therapeutic committees, and rational use of medicines, standard-based pharmaceutical management, and this is accreditation of pharmaceutical services, organization strategic management, and project management. So I think now you can tell why we really approached Dr. Jaguga to take us through this topic of today, that is AMR from a health system perspective, because of his really deep experience and knowledge across the health systems field. So he's a pharmacy graduate and he's a postgraduate certificate in clinical pharmacy, a master's of business administration in healthcare management, and a master's of science in global supply chain management. So thank you so much, Dr. Jaguga, for really availing your time. I know it's a bit late right now, but we really appreciate that you sacrificed and prioritized some time for us. Thank you so much, and over to you. Thank you.
Okay, thank you very much, Daniel. And again, just in a sound check that you can hear me.
Yes, we can hear you, Dr.
Oh, okay, thank you. Great. So thanks for extending the invitation, and nice to meet all the participants from various countries in Africa. So the topic that was given by Daniel is AMR from a health system view or perspective. And I'm talking to the AMR Ambassadors Program for Young People, Africa. So good to know that AMR is not something that is new, at least to the target audience. AMR standing for antimicrobial resistance. And so we are here to learn more about how health systems influence AMR, can contribute to AMR, what are some of the mitigation measures, basically, how AMR influences the health systems and vice versa. So going to my next slide. Sorry. So these are the objectives that was given. And it's my hope that we will achieve these objectives by the end of this session. So we hope to see how poor governance at health facility level influences AMR, can contribute to AMR. And so, of course, anytime you talk about poor governance systems, then you should talk about the best practices, how does good governance. And we'll touch a bit also at the global level, national level, and of course at the healthcare facility level. Inadequate healthcare resources and AMR, how constrained healthcare financing does contribute to the spread of antimicrobial resistance. Poor regulatory structures and how they contribute to AMR, poor quality antimicrobials, and potential low-lying fruits and critical penetration points to leverage on. So at the end of this session, it's my hope that we will gain the knowledge on the intrinsic relationship between poor health systems and the spread of AMR. And like I said, the reverse as well. So how does a good healthcare system, mitigate, control, or contain AMR? Then we should be able to appreciate the role of proper health systems in tackling AMR and the need for cross-cutting interventions that address the challenges from the core upwards. And finally, it is my desire that we will be inspired to think about the gaps in our health system that promote AMR and to create innovative solutions on how the gaps could be addressed. Now that I'm talking to students, I realize that there's the much that you can do now as students. There are the likely places that you'll find yourself working in after you graduate. And so I will try and tailor-make my interventions to your level and where you're likely to be post-graduation, but also just to give you an overview of what else is happening. out there. So this is not new. I believe we all know what antimicrobial resistance is, but I just thought it would be good to have that definition there. And this is borrowed from the WHO website, World Health Organization. So antimicrobial resistance occurs when bacteria, viruses, fungi, and parasites change over time and no longer respond to medicines, making infections harder to treat and increasing the risk of disease spread, severe illness, and death. So in simple terms, you have an infection, say pneumonia. The Streptococcus pneumonia has developed resistance so that the antibiotics that you'd use to treat your pneumonia, are no longer effective, whether it's your penicillins or your fluoroquinolones or your carbapenems, right? So if I have pneumonia today and no antibiotic is able to kill the bugs, then there's the risk of disease spread, severe illness, and unfortunately, ultimately death. And so what are antimicrobials? These include antibiotics, antivirals, antifungals, and antiparasitics. These are medicines used to prevent and treat infections in humans, animals, and plants. So note, and I guess this is something that you are also aware of by now, that antimicrobials are not just used in human beings, but are also used in animals, for treating infections, and in plants as well. And I'm glad to note, Daniel, like you said, that we not only have human health students, but we have those in other disciplines like animal health, agriculture. I hope we have students from the environment space as well. So now that we're talking about AMR from a health system perspective, I thought it would be good for us just to understand. So what exactly is a health system? Sometimes we use some of these terms, but it's just good to break it down and to use very, very simple definitions to help us understand what a health system is. So in very simple terms, grammatically speaking, a system is an arrangement of parts and their interconnections that come together for a purpose. Different components, different sections coming together to achieve a common good, a common purpose. That's a basic definition of what a system is. And so what is a health system? So a health system consists of all the organizations, institutions, resources, and people whose primary purpose is to improve health. Organizations here would include NGOs, like the one that I work for, the ones that I've worked for, would include health insurance companies, healthcare facilities, hospitals, dispensaries, the community pharmacies down the road, public health programs, ministries of health, suppliers of medical products, suppliers of medicines, suppliers of diagnostics, procurement agencies. I believe in each and every country, or most countries in Africa, there is a procurement agency for medical products or for health products and technologies for the country. There's the national warehouse or provincial warehouses, district warehouses, or county warehouses, depending on the system of governance in your in your country. So the health system consists of all these players, of course, including human resource, the nurse, the pharmacist, the lab guy. Basically the health human resource. So all those are involved in the health system. And they can contribute to AMR in one way or the other, or they can contribute to mitigating or containing AMR. So the health system delivers preventive, promotive, curative, and rehabilitative interventions through a combination of public health actions and the pyramid of healthcare facilities. Yeah, you find there's the pyramid of healthcare facilities in different countries, from a national referral hospital, maybe down to a provincial hospital, to a district hospital, to a dispensary. So all that constitutes the healthcare system. And like here, it states both state is government and non-state actors, even the private healthcare facilities. Some of you probably have worked in clinics, or somebody who owns a private clinic in your neighborhood. That forms part of the healthcare system. Their goal is to deliver preventive, promotive, corrective, and rehabilitative interventions. So the healthcare system's actions should be responsive and financially fair while treating people respectably. Yeah, so there's always the component of finance. Even if you're not paying out of pocket, somebody is paying for it. The government is paying for it. That government gets money from our tax. Or if a government has borrowed money from IMF or World Bank, the government is paying back that loan. So it needs to be financially fair and also needs to treat people respectably. Irrespective of your rank in society, a good healthcare system, whether I'm a doctor or a pharmacist or a sweeper, it should be able to treat me in a fair manner. The way that member of parliament will be treated is the same way, a sweeper who presents himself to a healthcare facility should be treated. So the healthcare system needs staff, funds, information, supplies, transport, communications, sorry about that, and overall guidance and direction to function. So these are just some of the critical components of the healthcare system that enable it to operate optimally. So we need human resource, we need funds, we need supplies. Supplies include, the medical devices, medicines. Transport sounds basic, but products have to move from one level of the supply chain to another, from the warehouse to healthcare facilities. There needs to be communication between all these players. And I like this last part, overall guidance and direction to function. There needs to be some level of, or some form of governance or leadership, organizing and ensuring that all these components of the healthcare system are operating the way they should. For me to get the desired health service that I need, when I present myself to a hospital, so many things are working in the background to ensure that I get the quality of care that I deserve, or you get the quality of care that you deserve. Somebody must have ensured that the medicines that are required have been procured and are available and have been stored well. Somebody must have ensured that the right human resource has been recruited and is readily available. You don't go to hospital, then that is when the hospital management is saying, oh, let us hire a doctor. They think through, they have that available. If it's a hospital that I've previously visited, there should be a system where my records are already in the system. Somebody can tell that, yes, Collins has been here 5 times. The last time he came, this is what he had. This was his medication history. This is what he took. This is what he went home with. There was a record of an allergy to tramadol. It is still visible. So somebody must have ensured that there's a system for managing information. So there's a lot that goes on by the time you're receiving that quality healthcare, there are many players that are in place. So this is just for us to appreciate the health system. So WHO has come up with, and I'm sure you may know this. Sorry about that. The typical health care system in a country has 6 pillars or building blocks. Leadership and governance, I've been talking about that. Financing, we've also touched about that. We need finances to hire the healthcare personnel. We need finances to purchase the medical products. We need finances to ensure that, for instance, if it's the health insurance that is paying for the bills, that money has to come from somewhere. So we need a healthcare workforce, the health information system, service delivery that also includes things to do with the availability of standard treatment guidelines, the availability of clinical guidelines for managing infections in this case. and medical products. It is in vain if all these are in place, but when your doctor says or prescribes your meropenem for you to be given if you're admitted, it is not available. Or we do not have cannulas and volusets for your medication to be administered. So a solid healthcare system has all these 6 components working optimally. Now, in many low and middle income countries, in many African countries, there are significant gaps in these pillars. There are significant gaps in leadership and governance. One, because most healthcare workers are not trained to be managers, are not trained to be leaders. We focus on medicine. So somebody is a good lab technician, is a good nurse, is a good pharmacist, is a good medical officer, is a good surgeon. And quite often we have these people hired or promoted to be the heads of healthcare facilities, but they lack management, training, and experience. You find in a province, for instance, or in a district, the district leaders or provincial leaders can decide to procure an MRI machine, and then at the end of that month, doctors, nurses, healthcare workers cannot be paid. So that is a gap in leadership and governance. Yeah. So in many African countries, there are significant gaps when it comes to leadership and governance. There's, of course, misappropriation of funds. We don't have adequate healthcare workforce. Our health information system is really, really wanting. Every time you go to a healthcare facility, you are being given a fresh file of fresh records. So somebody cannot tell that you came yesterday or day before yesterday and what you are managed for. Our healthcare information system cannot even track antibiotic use or antimicrobial use. If, for instance, you want to check how many vials of ceftriaxone have we used in the past 2 months or 3 months, in the past 1 year, we're not able to elicit that kind of data. How many patients, how many children with meningitis, bacterial meningitis, were treated with the right dose of ceftriaxone at 100 milligrams per kg? We cannot get that information because our health information systems are really, really wanting. Even basic procurement systems are really wanting. Our forecasting and quantification is really wanting because we do not have a system of tracking what was purchased last year, what was purchased last quarter, what have we consumed the last quarter, what is remaining, etc., etc. So many African countries have significant gaps in these key pillars that constitute a healthcare system. So in the next couple of minutes, we want to discuss how AMR is influenced by each of these 6 health system pillars. So in terms of health system governance and leadership, of course, it is good to know that there are already steps that have been undertaken, both from the global level, national, and even, I believe in your countries, there are efforts here and there to combat AMR. You may or may not be aware about some of these interventions. So AMR is already an agenda item in the UN General Assembly that takes place every September. Yeah. And this is a component of leadership. So it's good to note that there is good or fairly good governance and leadership at the global, at the global level. In WHO, there's this strategic and technical advisory group for AMR. So this is the principal advisory group to WHO on matters concerning AMR. So AMR is not only an agenda in the UN General Assembly, but even in the World Health Organization. And right now, it's not just an agenda in WHO, it's also an agenda with FAO, Food and Agricultural Organization. It's an agenda with the OIE, Organization for Animal Health, and UNEP a few years ago also joined. Remember, AMR is multi-sectoral. It cannot be fought just by the human health workers. We need people from the environment sector, animal health, the plant sector, etc., etc. So this team advises WHO on what needs to be done globally insofar as AMR is concerned. WHO, together with the multi-stakeholders, developed a global action plan on AMR. You may be aware of this, if I'm not wrong, in the year 2015 or 2017. And countries were encouraged to develop their own national action plans. In Kenya, we do have our own national action plan, which should have expired by now. I believe it's now due for revision. There's the global WHO toolkit for antimicrobial stewardship. Antimicrobial stewardship, in simple terms, is appropriate use of antibiotics, and especially in healthcare facilities. So how do you diagnose your pneumonia? How do you diagnose your acute otitis media? And what are the antibiotics or antimicrobials that need to be used? When do you use a high dose amoxicillin, for instance? When do you use a low dose amoxicillin? So it's basically appropriate use of antimicrobials for the right disease state. There are also global guidelines on infection prevention and control. Poor IPC measures contribute to infections, and when infections warrant the use of antimicrobials, and when there's an appropriate use of antimicrobials, then we get AMR. And so there are also global guidelines on IPC. So this is just to show you that at a global level, there is fairly good leadership and governance to combat AMR. The task is on countries now to implement some of these guidelines, to actualize them in their own countries. And then there is this GLASS, Global Antimicrobial Resistance and Use Surveillance System. It's basically a standardized approach. It offers guidance on how to collect, analyze, and share data on AMR. For us to be able to have trends across board, we need a standard approach of reporting AMR, of reporting antibiotic use, of reporting antibiotic consumption. So these guidelines just communicate that standard approach, and countries are encouraged to adapt and come up with their unique guidelines. Actually, countries are required to report to GLASS on their AMR trends. There are also global diagnostic stewardship guidelines. This simply means the appropriate use of lab testing to guide patient management in order to optimize clinical outcomes and limit AMR. Basic things like sample collection. If samples are poorly collected, if we collect contaminants and take to the lab and grow MRSA, and then say that this patient is suffering from MRSA, you see, we will be treating the wrong thing, quote unquote. So sample collection is key. So diagnostic stewardship guidelines really talk about the appropriate use of the lab to ensure that patients are managed optimally. So just to share at national and county level, I know some countries have provinces, and this is with a focus to Kenya. Those from different countries may relate to some of our interventions here. So at the national level in Kenya, we also have a fairly good governance and leadership structure to combat AMR. We are still not yet there, but we are making steps in the right direction. So the Pharmacy Influencers Board has been playing a key role in promoting, for instance, prescription-only medicines for antibiotics. In most African countries, you can walk into a retail pharmacy or a community pharmacy and procure amoxicillin and procure co-amoxiclav and procure levofloxacin. Strictly speaking, antibiotics shall be prescription-only medicines. You need to have a prescription from a medical practitioner who is licensed to prescribe for you, of course, after being examined. So our Pharmacy Influencers Board, which is the National Medicines Regulatory Agency is trying to put measures in place to ensure that antibiotics are prescription-only medicines. We are yet to get there. There are still significant gaps to ensure that the antimicrobials that are brought into the country are of good quality, because poor quality antimicrobials lead to AMR. The Pharmacy and Poisons Board periodically conducts post-marketing surveillance. Post-marketing surveillance, in simple terms, is where the board goes out there. If we decide we want to look at the quality of certain antimicrobials in the market, certain antifungals in the market. So we decide, say, we want to look at the quality of, ciprofloxacin. So we go to hospital A, pick a few samples, go to a retail pharmacy, pick a few samples, and test these in the National Quality Control Laboratory to see if they are of good quality in terms of assay, in terms of identity, in terms of purity, etc., etc. So I'm glad to report that the regulatory body in Kenya has taken AMR as an agenda, but we are still far from getting to the point where we are really where our efforts are containing AMR to a significant extent. Now, there are these abbreviations here which I should have expanded. So at the national level, we have the National Antimicrobial Stewardship Interagency Committee that is tasked with AMR activities nationally. And then at the county level, or what other countries may call the provincial level, we have the County Antimicrobial Stewardship Interagency Committee. Interagency because it involves people from the animal health, environment, plant health, water ministry as well. We even have representatives from the Department of Finance, or Ministry of Finance as well in these teams. Like we will see, or like we've even spoken about, we need money to implement these national action plans on AMR. And so I'm glad to report that we have this national body that oversees AMR activities, and counties are encouraged, and provinces are encouraged to have their own county governance mechanisms on AMR. I think currently, out of the 47 counties that we have in Kenya, I think we have about 8 to 10 CASICs, as we call them, at the county level. Remember, this is a multi-sectoral team. So glad to note that we also have national action. We have a national action plan on AMR that is said now and is due for revision. We also have a national antimicrobial stewardship guidelines for use in healthcare facilities and the community. You can actually get these documents online, but if need be, I can share them with Daniel, and Daniel can in turn share with you. We have national infection prevention and control guidelines. We have national AMR surveillance guidelines. We have treatment guidelines for infectious diseases, but they're obsolete. Currently, there is a National Medicines and Therapeutics Committee that is working on developing newer treatment guidelines for infectious diseases, so that as a country, we are saying that first line for Neisseria meningitis is this, second line is this, third line is this. Happy to say that we also have the Kenya Essential Medicines list. This is basically a list of medicines that are to be used to manage or to treat the priority diseases in Kenya. I was part of the team that revised the 2019 Kenya Essential Medicines list, and in that list we added what we call the aware classification of antibiotics. You may be aware of this. This is a concept that WHO introduced about 4 or 5 years ago. So aware stands for, the A stands for access, watch, WA stands for watch, RE stands for reserve. So the access antibiotics or antimicrobials are those that are readily readily available and are mostly first line, some second line antibiotics for common conditions, like your gastroenteritis, which is infectious, hepatitis media, pneumonia, meningitis, cellulitis, etc. And we went ahead and defined ideally who should prescribe these. So the medical officer or those who have done a diploma in medicine. And then the watch categories, these ones and then the access can be prescribed empirically. The watch and reserve, we prefer that a culture sensitivity test is done. We've even defined the specialists to prescribe the watch and reserve, because these are basically these are the big guns that we want to protect, we want to preserve. We don't want to have them readily available. We don't want to have them prescribed by anyone, because if we misuse our last lines of defense, what will happen? The day you have that patient in ICU who needs meropenem, who needs the fourth generation cephalosporins, if we have misused them, then what will this patient use? And then reserve now are restricted, specialists, consultants are the ones who can prescribe these medicines, and with justification. These include vancomycin. Yeah, so it's again a way of trying to control prescribing of antibiotics with the aim of restricting AMR. Otherwise, when you leave it open, then anyone prescribes anything. Ceftriaxone, I'm sure not just in Kenya, but in many African countries, is used for anything. Very soon, ceftriaxone will be a cephalosporin that we'll be talking about in the past. Now, at the facility level, it's important to have these governance structures to contain antimicrobial resistance. So depending on your facility, whether it's private or public or faith-based, and the terms that are used, the typical private healthcare facility in Kenya, for instance, will have a medical advisory committee. So if tomorrow you are posted to a healthcare facility, even during internship, you should be bold enough to ask, is AMR an agenda item in the medical advisory committee? Usually, the medical advisory committees involve different specialties meeting to discuss best practices for managing patients, gynecology, dental, dermatology. We have representatives, and where there are challenges, these are discussed. Where there is need for guidelines, these are developed. So is AMR an agenda item? Is antimicrobial stewardship an agenda item at the MAC level? Is infection prevention and control an agenda item at the MAC level? Is diagnostic stewardship an agenda item at the MAC level? So these are things that you can push for so that they become an agenda item at that level. Many times, and especially in African settings, if the leadership does not buy into something, it will hardly be adhered to, it will hardly be followed, it will not be taken seriously. But if it comes from the medical advisory committee that AMR is a global problem, from today onwards, we want to start tracking AMR. Our labs don't have the capacity to do culture and sensitivity tests, but we want to allocate resources so that our lab can be able to do that. Prescribers need to know that before they prescribe this category of antibiotics, it's important that we have a culture and sensitivity report from the lab. The lab guys need to develop antibiograms, basically trends. of culture and sensitivities over a period of time, usually a year, that informs also, future prescribing or even current prescribing. And the medicines and therapeutics committees generally oversee the use of medicines in a healthcare facility. So as an intern, as a fresh graduate, and you've started working in this facility, so number one, do you have a mark? Do you have a medicines and therapeutics committee? If it is not there, can you push for it to be established? If it is there, is AMR an agenda? Is antimicrobial stewardship an agenda? Do you have guidelines? Do you have SOPs? Yeah, facilities or hospitals that can come up with antimicrobial stewardship teams, well and good. Usually the antimicrobial stewardship team is a subcommittee of the MTC, because the MTC will look at several things, including procurement, including medication safety, pharmacovigilance, post-marketing surveillance. So antimicrobial stewardship can be a subcommittee of the MTC. The AMS team can participate in ward rounds and ensure that medicines being prescribed. So they actually even guide prescribing of antimicrobials in the wards during ward rounds. Antimicrobial stewardship teams comprise of an infectious disease expert, if available. If not available, it can even be a nurse who has the interest and passion for good prescribing of antimicrobials or optimal use of antimicrobials. So it could be a pharmaceutical technician, a pharmaceutical technologist, but generally it's a multidisciplinary team. But as a pharmacist, a medical officer, infectious disease experts, clinical pharmacists, if available, nurses, laboratory scientists as well, IPC teams. So is there an IPC committee? Are we tracking health-associated infections? So these are some of the roles of the IPC committee. So you get to this hospital as a fresh graduate, and you'll find that many healthcare can hear me. I received an alarm, internet connection unstable. Daniel, just checking that you can hear me.
Yeah, I can hear you, man. Dr. Jaguga.
Okay, fine. Yes, so what are some of the things that the infection prevention and control teams do, tracking healthcare-associated infections, which are largely due to poor hand hygiene that is proven, where doctors move from one patient to another without washing their hands, nurses move from patient to patient without washing their hands, infections as a result of catheterization. So hand hygiene is key, and a very simple activity that the IPC team can do is to sensitize healthcare workers on hand hygiene and hand washing, because this has been shown to really spread these superbugs from patient to patient. Many healthcare workers, most of us have cell phones, and there was a healthcare facility. I was in a conference and somebody was giving a presentation about the cell phones that healthcare workers have. So they were swabbed and cultured, and what was grown was really shocking. In simple terms, it revealed, the results of the cultures revealed that most healthcare workers were not washing their hands when they go for short calls. So that's a very basic thing that an IPC team can do, that even as a student, you can push to sensitize all healthcare workers on good hand hygiene practices, monitor hand washing, even if you just focus on one ward and come up with a report and share that in this ward, hand washing is at 40%. These are the 5 opportunities that we should have hand washing in this ward. But on doing an audit, usually you just stand in one corner of the ward and observe the nurses. So observe these nurses as they move from one patient to another. As they are moving from one patient, touching the records and back to the patient, are they cleaning their hands? And doing those audits and conducting a brief talk, exercising them on where the gaps are. Facility clinical guidelines on antimicrobial use. Again, this is an area that you can easily intervene even as a student when you get to a hospital and just find out, do you have clinical guidelines? Do you have guidelines on antimicrobial use? Or is every doctor prescribing what they want for any infection? Yeah. So these are interventions that help contain AMR, and these are things that you can do at a healthcare facility level. So on to the second pillar, the health financing pillar. So just to let you know that AMR generally in most countries is not a financing priority for many low and middle income countries. So for many low and middle income countries, AMR is not a priority for our governments, unfortunately so. And not just our governments, even our ministries of health. And I think it's because AMR does not have a face. Yeah. Somebody a patient who has a superbug does not have a characteristic face. HIV/AIDS, it was evident, there was wasting away, but AMR doesn't have a face, and it takes a bit of education, a bit of lobbying for the average politician to understand the concept of AMR. And for as long as politicians do not understand what AMR is, they will not allocate finances for AMR. Yes, you can develop a national action plan on AMR and list everything that you want to do in terms of awareness on AMR to the public, awareness on AMR to farmers. Your national action plan may have interventions on surveillance, antimicrobial stewardship, even research and development, but all these need financing. And governments are responsible for ensuring that national action plans are funded, but it is our responsibility as healthcare workers or animal health workers or people from the environment to lobby and to demonstrate what difference will it make for a government to part with $100,000 or $1 million to allocate $1 million for the fight against AMR. So finances are required. So inadequate financial support. Sorry, there's something blocking. Okay. So inadequate financial support currently available for the sustainable implementation of national action plans on AMR, particularly in LMICs. We've said that. You may be aware that pharmaceutical firms are no longer keen on producing new antimicrobials. Why? Because even with judicious use, eventually microorganisms develop resistance. You know that concept of survival of the fittest, if you remember your evolution in biology. So they would rather invest their resources on medicines that are used for long-term or for chronic conditions. Today, if I have diabetes today, I'm likely to be on antidiabetics for years, as opposed to an infection that I may need at most, 14 days, but usually 5 to 7 days, right? So pharmaceutical firms need incentives, they need finances for them to develop new antibiotics or alternatives so that we do not get to the pre-antibiotic era, the era before antibiotics, when even a simple flu or a simple infection will kill you. Because once all our antibiotics are not effective, then we risk going back to that pre-antibiotic era where no antibiotic can work. And so any infection will kill you. Money is needed if we are to do AMR related research and development. And this not only in human health, but also in animal health, food, plant, and environmental sectors. So in other words, it's one thing to have leadership and governance in place. It's one thing to have all those plans. Even coming up with those plans needs finances. But without solid healthcare financing, without our governments allocating finances for AMR is likely to be the next global pandemic, if it is not already. Actually, in certain quarters, it is called a silent pandemic. It is not as loud as COVID-19. It is a pandemic, yes, but it is silent. And we do not want to wait until we are losing more than, I think the data that we have from WHO of 2016 was about 700,000 people dying annually as a result of AMR. The figures could be higher now. We do not know what the figures are in Africa. Human resource, I think this goes without saying. There's need for awareness, there's need for understanding of AMR through effective communication, education, and training. Yeah, most of us are not aware about AMR. Most of us are not about AMR in school. We learn AMR through associations like this one, or through media, or through conferences. So the average African citizen does not know about AMR, but the average person has an idea what COVID-19 is. And so the other day we were asking ourselves with some colleagues, it is possible that out of the 7 billion people in the world right now, it's possible that over 90%, yeah, or close to 100% of the human race know what COVID-19 is. So what was different? What has been different with COVID-19? Why is it that AMR is not known to that extent? Yet AMR was there even before COVID-19. What is it that happened so that COVID-19 has been able to reach everyone, possibly over 6 billion, close to 7 billion people? My rough estimate is probably just a third of the world, or even less, maybe even 10%. If you're walking today randomly, in town, and you decided to stop somebody and ask them what AMR is, it's likely that only 1 out of 10 will have an idea. So there's need for awareness, and this awareness, so there's need for we now who are being trained to go out there and and talk about AMR and talk about avoiding over-the-counter use of medicines, and talk about not sharing antibiotics at home. We need skilled human resource when it comes to surveillance and research in the area of AMR. We need well-trained lab folks. We need experts in infection prevention and control. We need people who have been trained on antimicrobial stewardship. There are quite a number of online courses on antimicrobial stewardship, a number of online courses on IPC. You can develop your own capacity and in turn, train your colleagues in the workplaces. So this is a challenge for some of us probably who are even interns. Read something on antimicrobial stewardship and tell. So of course, this is now for those who work in the hospital setting. Tell your hospital in charge or the pharmacy in charge or the medical personnel that you like to give a small talk to other healthcare workers, even within healthcare facilities or within hospitals. Not many people know what IPC is all about. Not many people know what antimicrobial stewardship is. So there's need for skilled human resource, because for as long as the know-how is missing, then AMR is bound to continue spreading. Pre-service training is important. I've participated in developing a curriculum for the School of Pharmacy, University of Nairobi, just to train them on what AMR is and what antimicrobial stewardship is, what infection prevention and control is. So by the time they are graduating, they are armed with the basic knowledge of what they can do once they go to some of these hospitals. Because sometimes you are posted to a hospital to do internship, and you're the first one to introduce that concept of antimicrobial stewardship. They've never heard about it. They've never heard of appropriate use of antibiotics. Every prescriber does what they want. So we notice that this is a gap. Many institutions of higher learning do not equip students with these skills. And so we're making efforts to train students in the university, and even in secondary level, high school, or even primary. Let that primary school child know that I should not share my medicines or my antibiotics with another family member, etc., etc. So there's need for skilled human resource there of AMR, and not just human health, animal health, environment as well. In-service trainings and continuing professional development sessions, these are important. And again, all these go towards developing a human resource on AMR. The One Health approach I've talked about, we need to understand how AMR cuts across the environment. When we discard antibiotics, when you use your antibiotic and some remain and discard it in the toilet, or you throw it in the farm, what happens to the microorganisms in the soil? When the cows, when animals eat the foods or whatever it is that is on the ground, and these bugs are transmitted into them, and these are the same animals that we buy from the butchers, are these superbugs, getting back to us as human beings? So that connection of AMR between the human health, environment, animal health is very important. We need people who have the knowledge so that they can be able to educate others. Sorry, I talked about health information management systems, surveillance and research. All these require good data management tools. There are very simple audits that you can do within your hospital, even if not hospital, sorry. Even in the animal sector, if you are a vet, and depending on where you work, you have a system that can track which animals have been given which antibiotics, antimicrobials, and for which conditions. Yeah, there's a lot that you can decipher or you can elicit just by analyzing trends. But the entry point is having these data in some form of database, even if it is just a simple Excel sheet. But unfortunately, in Africa, we are not good at data collection. And so our health management systems are very, very poor. And some of these systems actually cost a lot of money. Clinical decision support systems. This especially can come in handy in a hospital where you have your treatment guidelines and the health information management system. So if you put a diagnosis of pneumonia, before you prescribe, it's already giving you the list of medicines according to your guidelines that you can select from. So you cannot go out of that list. So that restricts your prescribing and ensures that you prescribe optimally. Right? I'm not sure we have some of these systems, but I know there are private hospitals that have some of these systems. So the doctor types in a diagnosis of acute gastroenteritis, and the options that appear are limited in terms of what to prescribe. Yeah. Do our health information systems have what it takes to track consumption? Can we say that in the month of January, we consumed 800 vials of ceftriaxone. In February, we consumed 2,000. And is there an explanation? Why is it that in the month of February, we consumed 2,000 vials, and in January, we consumed 700? Was there influence from pharmaceutical firms, or was there an upsurge in a certain disease state that warranted the prescribing of a particular antibiotic. So you cannot interrogate, you cannot have such questions if you don't have a system for tracking these. Because when you have such a system, then you're able to pick where there may have been a lapse, right? Maybe there was a pharmaceutical company that came and promoted a particular antibiotic, and that's why that particular month there's an increase in the use. And that also means that it is likely that there was inappropriate use. And so you now drill down, and if you've got guidelines, then you start asking yourself, so for azithromycin, what are the indications in our hospital for the use of azithromycin, for instance? And then now you want to audit. So all these 2,000 patients, for instance, who are on azithromycin, were they managed according to guidelines? Did they really need azithromycin? Then you may discover that probably 60, 70% of them did not need azithromycin as per the guidelines. Then you want to narrow down and start and have talks with prescribers and communicate when should we use azithromycin, or for these conditions that azithromycin was used, what ought to have been used. So again, you need a very solid health information management system for you to be able to conduct some of these activities, which end up containing antimicrobial resistance. So when your health information management system is very weak, then anyone will prescribe anything, we will not know trends, people will be managed, patients will be managed with the wrong antimicrobials, right? And it's these trends that end up assisting us in changing policy, whether it's at the facility level, that is at the hospital level, or county level, or even national level. We are now coming to the end. Service delivery and medical products. I've mentioned some of these things. So service delivery is a key health system pillar, and so is medical products. Some people say no product, no healthcare. So effective service delivery is guided by having clinical guidelines. And like I said, it's not enough to have these clinical guidelines. There needs to be adherence to clinical guidelines. So these are some of the things that as a student, when you go to your hospitals, you can do or you can catalyze so that there is appropriate use of antibiotics and thereby, slow down AMR. Just a simple question, all these patients on this antibiotic, are they being managed according to the guidelines? What do the guidelines say? Chances are that the guidelines are not even there. So can we start? You can even just start by one condition. So pneumonia, the various types of pneumonia. Can we as a hospital come up with the guidelines? This also applies to animal health. The typical African setting, your animal is sick, there'll be this veterinary doctor, quote unquote, in the village. We do not know where they studied. They will show up and give your animal, give your cow some medication, some tetracycline, some doxycycline, some erythromycin, some amoxicillin, without taking any sample. The typical African veterinary doctor, quote unquote, I'm calling them veterinary doctor, will just come, treat your animal, and leave. Yeah. So do we even have clinical guidelines for managing infections in animals? And are we monitoring adherence to these clinical guidelines? So it's good to challenge your hospitals. Can we have a system where so all these patients who presented with pneumonia last month, even if you just take a sample of 10 out of the 50 who came, were they managed according to our clinical guidelines? Are they getting the best care possible? What about the adherence to essential medicines list? Are we procuring medicines in line with the medicines list, or are we procuring medicines outside the essential medicines list? Are we tracking how many reserve antimicrobials are we buying, and are they being used according to guidelines? How many watch antibiotics? How many access antibiotics? So adherence to access, watch, and reserve categorization of medicines. If your hospital policy requires that all reserve antibiotics must be pre-authorized before dispensing, was that actually done? If we need a culture and sensitivity report for the watch antibiotics, was that actually done? Yeah. What about medication use counseling? Just a minute. Sorry for the small interruption. Yeah, medication use counseling, very, very important. Do we take the time to educate our patients? This is now to, pharmacists especially, but even nurses do dispense medicines. In Africa, the many healthcare workers who participate in dispensing medicines, do we advise patients to complete their full course? When you tell a patient to take the amoxicillin, 1 capsule, 500 milligrams, 3 times a day, what does 3 times a day actually mean? You encourage them to take their medication for the 5 days or 7 days or 10 days as prescribed. Do we engage them to understand their lifestyle? How practical, how easy will it be for this person to take their erythromycin 4 times a day? Yeah, because definitely that high frequency will reduce compliance. The patient will miss some doses, may not finish altogether, and that will contribute to AMR. So do we take the time to educate our patients on medication use, how to use the medicines? How should they dispose whatever will remain? If you dispensed a bottle of amoxicillin, for instance, and the patient is taking 5 ml, 3 times a day for 5 days, the whole bottle is 100 ml. So the patient will use 15 times 5, 75 ml. So what about the 25 ml that is remaining? How should it be discarded? Yeah, WHO is discouraging fixed dose combinations of antibiotics that have different pharmacokinetic profiles, because again, this encourages inappropriate prescribing. You find an antiprotozoal has been mixed with a fluoroquinolone. The rationale is not very clear. And again, this leads to AMR. Self-prescribing of antibiotics, we talked about this. You have a cough, you have a flu, you have a viral infection, you have a mild sore throat, and you quickly go to a pharmacy and you're asking for an antibiotic, which you don't need in the first place. Most pharyngitis, most sore throats are viral. Most gastroenteritis infections are viral, are self-limiting. You don't need an antibiotic, but you find most of us will walk to a pharmacy, ask for that antibiotic that we don't need, and will contribute to AMR. So that is it from me. Any questions? I don't know, Daniel, do you want the participants to ask verbally? Are they putting the questions in the chat?
Yes, thank you so much, Dr. Jaguga, for that. Yeah, so we have a question in the chat, but also I'd also shared when we started. If you also have a question, you can just raise your hand this time, then at least you can share verbally. I think we have 2 participants who already raised their hand, but we can take first the one from the chat, and it was from Jennifer. And Jennifer just wanted some more clarification on the whole aspect of surveillance and how they get to know about, just some more clarification on the cultures and the sensitivity tests and how we link this with surveillance. Yeah. Hello, Dr. Jaguga. Hello. You're on mute.
Sorry, are you able to hear me?
Yes.
Oh, yes. Okay, so yeah, I was trying to read the question. So surveillance is really a very generic term. Surveillance can be broad in the sense, if we are doing culture sensitivity tests, right? So what are the trends of resistance in our healthcare facility to a particular microorganism? You usually need like about 30 isolates for you to come up with a decision that this bug seems to have developed resistance to this particular antibiotic, right? So AMR trends. Surveillance can even be in terms of tracking consumption. Yeah. And then there's a question here, how do they get to know which drugs are not working? So you take a culture, can be stool, can be blood, can be sputum. It is cultured in the lab, which microorganisms will grow. And then it is tested against certain antibiotics, right? To know which antibiotics are sensitive and which ones are not sensitive. So that responds to how do they get to know which drugs are not working. But surveillance is generally broad, just beyond tracking the bugs that are resistant. It's also tracking antibiotic use. Surveillance also includes what I was saying, even doing audits on clinical guidelines. How many patients who have presented with a particular disease state or an infection are being managed according to guidelines? So surveillance is a generic term to track trends when it comes to management of infections, antimicrobial use, AMR trends. I hope I've been able to respond to that. I can see, but feel free just to ask Jennifer if something is not clear. Somebody here says, thank you. Marie from Rwanda. As we know, most problems are solved by technology. So is there technology which is there to solve this AMR problem? AMR is multifaceted. I wouldn't say that we can have one technology that can sort out everything. But technology for sure can contribute to containing AMR. Like I said, if your hospital can afford to have a system that the moment the prescriber puts the diagnosis, the system already has the medicines that should be prescribed for that particular infection. So in other words, you're not at liberty to prescribe any antibiotic. So it limits you, probably depending on your diagnosis. If it's a simple, a simple upper respiratory tract infection, it may limit you probably to amoxicillin or at the most co-amoxiclav. So it restricts. So in that case, technology is helping you to prescribe optimally for that particular condition. But I don't think there's technology that will sort out awareness and education. The same technology will do surveillance. The same technology will do antimicrobial stewardship. The same technology will coordinate infection prevention and control. I hope that answers your question. Question, would like to find out, in resource-limited settings without adequate health information systems, how best can we practically attempt surveillance of antimicrobial use? Yes, thanks, Pius Musonda from Zambia. like I said, we can be creative. We can use simple tools like an Excel sheet can do. Of course, there has got to be human input. There's got to be somebody who has to sit and update this Excel sheet every day in terms of what has come in and what is being used on a daily basis. And you may want to progress beyond just numbers. Out of these 10 vials of vancomycin that were used today, what were they used for? Even at a minimum, diagnosis. Yeah. So there's something that you can do even with just an Excel sheet, even with just the medication name and diagnosis. And then you can dig deeper and ask yourself, so out of these 10 patients who are on vancomycin today, what were the indications? What were the diagnoses? And is there a correlation between use of vancomycin and the diagnosis cited? So in low resource settings, if you're just focusing on consumption without necessarily looking at the diagnosis, then bin cards can still suffice. Even just a query, like I mentioned, we seem to have used a lot of this particular antibiotic this month. What could have happened? Yeah. So use of an Excel sheet, use of bin cards could do. You mentioned the structure of the health system and pyramid as a case. Are there challenges to curbing AMR that arise because of the structure of our health system? Are there challenges to curb AMR that arise because of the structure of our healthcare system? Yes, for sure. There's been debate, for instance, in Kenya about what level of the healthcare system or of the healthcare system pyramid that we should have ceftriaxone, right? So when we're coming up with the Kenya Essential Medicines list, there are people who are of the view that ceftriaxone should be at hospitals at level 4, 5 and above. Maybe in some countries, maybe those are district hospitals, provincial hospitals and above. Others are of the opinion that let's have that ceftriaxone even at the health center level. Why? Because somebody will present with meningitis, for instance. Maybe that meningitis cannot even be diagnosed at the health center, but that is the nearest healthcare facility to this person. Based on presentation of symptoms, that nurse there may decide to give this broad spectrum ceftriaxone to save the life of this patient, because the next hospital, the higher level, is several kilometers away. And this patient does not have even the fare to get to this other hospital, where a proper diagnosis of meningitis can be made for this patient to receive ceftriaxone. So there's a debate. So do we make ceftriaxone readily available at a health center and risk it being misused, because every other patient then who comes with an infection will be given this broad spectrum antibiotic? Or do we just limit this health center to have amoxicillin and the basic antibiotics, first-line antibiotics and ceftriaxone at a higher level, and we strengthen the system of transferring a patient from this lower level to the higher level? Yeah. So the process of transfer may be a challenge, like you may all be aware in many African countries, especially in those very remote areas. So if the decision is to have ceftriaxone readily available, then we will be contributing to AMR, because this person at the healthcare center will be dispensing or administering ceftriaxone to anyone who presents with an infection. So sometimes there are no straight answers. We also have, in many countries, community healthcare workers who go around, and sometimes most of them, their focus is on maybe children below 5. And there's a debate as to whether they need to be moving around with amoxicillin to treat any kids that they find who they suspect are suffering from pneumonia. So would you rather have this health care worker have amoxicillin in their cabinet that they're moving around with from village to village in that heat and hopefully save a child, or not have the amoxicillin and have increased mortality from pneumonia? There are no straight answers, but these are some of the challenges that we face. Sorry, okay, the questions are streaming in.
Hello, Dr. Jaguga. Maybe I can read for you the next one, if you don't mind.
Okay, yeah, sure.
Yeah, thank you. So the next question is from from Dion and Dion Mageza. So the question is, how best do we deal with the issue of doctors prescribing antibiotics for all kinds of sore throats, as well as flu caused by virus? And as much as we speak about educating them, I don't know how best to raise awareness on this issue. Something I come across every day. It's probably out of people's ignorance, but how do we help in that in reality? Thank you.
Yes, usually the best people to educate doctors are fellow doctors themselves, at least from experience working in a hospital. So if you can have a doctor being a convert of appropriate use of antimicrobials, then you make them the chair of the Antimicrobial Stewardship Committee or the chair of the Medicines and Therapeutics Committee, or you call a fellow doctor, you call a doctor to give that talk to other doctors on appropriate use of antibiotics, and the topic is management of pharyngitis. So let that doctor communicate what best practice is, and let the others also share their experiences and their challenges. It is not easy. It is not a war that can be won overnight. But we found that working well when you saw that it's a fellow doctor standing in front there, giving a talk to other doctors about how we should not be prescribing antibiotics for all sorts of sore throats. Most of them are viral, and there's no benefit in prescribing an antibiotic for a viral infection. When it comes to the public, I guess it's just continuing to tell them what is the best practice. Yes, please. You can read the next. I can see time is really moving.
Thank you. Yeah, so I think we can just take 2 more questions. Then we can just use you, Dr. Jaguga. Then maybe I'll email you the rest. Then when you have something, you can just answer because of.
Sure.
Okay, thank you. So just another question that is a bit related to that, and from Idris Oraduso from Nigeria. So the question is, my question is, what is currently limiting health workers, especially doctors and pharmacists, from usage and access of antibiotic prescription guidelines at the moment?
I don't know. I guess it's more of a behavioral issue where, okay, one, many settings do not have guidelines in the first place for managing common infections. The few where there are guidelines, there's a challenge of adhering to these guidelines. So using these guidelines. Education comes in sensitizing healthcare workers and sensitizing doctors, especially during orientation and even on an ongoing basis. So best practice is, if you have guidelines during orientation, when a doctor is recruited in a healthcare facility, the orientation should include what we prescribe in this hospital for what conditions, insofar as antibiotics is concerned, or managing infections, right? And then it's not enough to stop there. Auditing. It is said that what is monitored is attended to. If I know that you're going to monitor my prescribing habits, then it will make me keep referring to the guidelines or read the guidelines so that I'm aware of what I should be prescribing for what conditions. So I worked in a hospital where we used to audit the prescribing trends of doctors, and we used to give them feedback both as a group and individually. So like I've kept saying, so like we take all the, okay, we take 20 patients every month. So we'll sample 20 patients randomly, say who presented with acute gastroenteritis. So what do the guidelines say? And how are these 20 patients managed, right? Then we find that, for instance, 18 of them were put on antibiotics. Say the guidelines say that they don't need to be on antibiotics based on the type of acute GE, right? And then we communicate to the patients. Then we have a doctor do a talk to fellow doctors on how best to manage acute gastroenteritis. What are the different types and what do the guidelines say? During those discussions, you will find that there may be need to modify the guidelines in view of best practices. When you have such forum, you get the doctors buy into best practices. Now, in addition to this group data that says out of these 20 patients, 18 were not managed well, and these were the gaps that we picked, each doctor receives their own report that out of these 20, there were 2 patients who are yours. And out of these 2 patients, none of them, you didn't manage both patients according to the guidelines. So over time, if I'm a prescriber, if I'm a doctor, I'm compelled to do the right thing by adhering to the guidelines so that I don't get that report that, you know, my patients are not being managed according to guidelines. So that is something that worked for us, but other ideas are welcome. So, but it's usually a behavioral issue. It's usually a behavioral issue where sometimes doctors just don't want to refer to the guidelines. They just want to treat based on what either they learned in school or what they've read elsewhere. Thank you, Ndova.
Thank you, Dr. Jaguga. Let's just take one last from Samuel, who had raised their hand, but they have shared it here. And
Okay.
so the question is, how do we properly dispose drugs? It's asking about how do we best dispose drugs to avoid AMR? So we can just answer that one as the last one.
Okay, thanks. So there are national guidelines, and hopefully every country has those guidelines on which categories of medicines need to be disposed in what manner. Others it's incineration at certain degrees. Others, burying in a barrel, like you put the medicines in a barrel and put concrete, seal, and then bury. What we do, and we try to encourage patients in Kenya, is do not discard your medicines. Any unused medicines, return to your pharmacy or return to the hospital where you procured. And then we have these disposal firms that are engaged, and they come and and they take and they dispose of in the presence of the Pharmacy and Poisons Board in accordance to the guidelines. So at a minimum, I don't know whether this can work in other countries, but we discourage patients from disposing medicines themselves, because the typical person will throw into the dustbin, throw into the toilet, or just throw into the farm. So that is highly discouraged. I hope I've responded.
Thank you. Thank you so much, Dr. Jaguga, for that. Maybe John, you can share. That's okay. And just for the other questions, I've saved them, so I'll share with our guest speaker, Dr. Jaguga. So in case your question is not answered, we'll just address it because our team has really gone. So I'll just love to thank you, Dr. Jaguga, for really availing your time for the sacrifice. And it's a great honor, and I'm really humbled that you really took this time. I know it's quite late on your end, but we really do appreciate your willingness to engage and great kindness. Thank you so much, and we really do appreciate. To our students, thank you too, and we hope that you've learned something else today, and at least from it, at least you're able to meet one of the outcomes of the meeting. And we are all your fresh minds, so I'm sure that maybe someone somewhere will try and come up with an intervention somewhere to address some of the gaps in our local setting. So thank you so much. Maybe Dr. Jaguga, do you have any last words as we close off?
Not really. Mine is just to thank you all for listening to me. I hope you've learned something, and I'm happy to respond to the questions that I didn't respond to. Even those that I responded to, you can just send me all the questions and I'll type responses and share back. Just thank you and wishing you well in your studies and in your career ahead. Thank you, Dover.
Thank you so much, Dr. Jaguga. Do have a wonderful night, and we really do appreciate. Thank you everyone else who made time to join the session, and see you in the next session. Thanks so much, and have a good evening to us all. Thank you. Bye-bye.
Okay. Bye.